Welcome to part 4 of pain. We will discuss pain medications. Any medication used to treat pain is also called an analgesic. There are 3 types of analgesics: opioids, non-opioids, and adjuvants. This PowerPoint is going to discuss all 3 of them. When providers prescribe analgesics, medications that relieve pain, they try to start with non-opioid or non-narcotic medications first. Of course, that will be dependent on what's causing the pain. We don't use non-opioids if someone just had their leg cut off, for an example. There are 3 main non-opioid medications used. The first is acetaminophen or Tylenol. Acetaminophen is a drug all on its own. It doesn't have its own drug class with other medications in it. It's just Tylenol by itself. Then we have NSAIDs, or non-steroidal anti-inflammatory drugs. This class of drugs has many medications in it, and some of them are very common, like ibuprofen, naproxen, celecoxib, and ketorolac. Aspirin is also considered an NSAID, but it has some other properties in it that makes it a multi-class medication. So like I said, acetaminophen is a drug all on its own. It's not 100% understood how it works, but we know it works in the brain and the spinal cord, and we know it's not an NSAID, and it has no anti-inflammatory properties. We do know that acetaminophen inhibits the synapses of prostaglandins that may be an inhibitor of pain and fever in the central nervous system. Therefore, we use it to reduce fever and to treat mild to moderate pain. It has a synergistic, or it works stronger and better when it's combined with other medications, especially narcotics. Acetaminophen is metabolized in the liver and then it's excreted by the kidneys, and it starts to onset in about 10 to 30 minutes, peaks around 30 to 120 minutes, and it has a duration of 3 to 4 hours. So acetaminophen is over the counter, but that does not mean it's safe, and it does have issues. The most common side effects from acetaminophen are skin reddening, blisters, rash, itching, urticaria, or hepatotoxicity, which is liver damage caused by the drug. The liver damage from acetaminophen can occur if the patient is taking more than 4,000 milligrams of acetaminophen in 24 hours. If they're geriatric, we drop that number to 3,200 milligrams, and if they're chronic alcoholics, we drop it even lower to 2,000 milligrams a day. And this is from all sources of acetaminophen, and that stuff is in everything. Cold medications, headache medications, combination drugs, it's literally everywhere. And because it's over the counter, so many people don't realize that they take way too much acetaminophen, especially when they're sick. Liver failure from acetaminophen can be from prolonged use at high doses, or it can occur from one very large dose, like an overdose. If someone does overdose on Tylenol, there is an antidote called acetylcysteine, but it is not a guarantee to stop the damage from the overdose. Contraindications for taking acetaminophen include people who are using warfarin, as it can lower platelets, people in liver or kidney failure, as they won't be able to metabolize and excrete the acetaminophen, and people taking NSAIDs should stay away from acetaminophen because NSAIDs like to damage kidneys, which then means they can't filter out the acetaminophen. Also, people who drink alcohol should avoid acetaminophen due to the liver damage effects from both the alcohol and the acetaminophen. Before we give acetaminophen for pain, we of course need to assess the pain, assess any liver and kidney studies the patient may have to make sure their liver and kidneys are functioning, assess their eyes and nose to make sure they're making urine, and of course, assess for any allergies to acetaminophen. After we give it, we need to reevaluate their pain to see if the medication worked. In addition to all of this, we need to make sure we're not giving too much acetaminophen. We need to look at all the medications we're giving to make sure nothing else has acetaminophen in it. Patient teaching and education we need to provide are very similar to what we need to do. They need to be instructed on how and when to take the medication. They need to know not to take more than the recommended daily dose, check all the labels to make sure it's not in other medications they're taking, and they shouldn't take acetaminophen for more than 10 days, and they should notify their provider if the pain lasts longer than that. Additionally, people should avoid taking alcohol while using this medication, and that's a big part of our education, as alcohol use and abuse are very common in America. They also need to know the signs and symptoms of acute toxicity and what to do if they suspect that's occurring. NSAIDs are a classification of non-opioid analgesics that are not steroids but do have anti-inflammatory properties. They also work to lower fever, and some, such as aspirin, also have an antiplatelet effect. They're used to treat mild to moderate pain, and it's a pretty large group of medications. NSAIDs relieve pain by inhibiting the synthesis of prostaglandin by different forms of the COX enzyme. COX-1 and COX-2 inhibitors stop the synthesis of prostaglandins, which cause pain, fever, and inflammation. In addition to causing these, COX-1 has an extra property that specifically synthesizes beneficial prostaglandins to protect the GI mucosa, and COX-2 just does the pain and inflammation. Most NSAIDs are non-selective as far as which COX they inhibit, so they're going to have side effects of both COX-1 and COX-2 inhibition. But aspirin specifically inhibits COX-1 only, and celecoxib is the only drug in America that currently inhibits COX-2 only. Because aspirin inhibits COX-1, it also inhibits COX-1 found in platelets, which means it's going to inhibit platelet aggregation, which is platelets sticking together to form a blood clot. So aspirin is used to prevent clotting, as in like a heart attack or a stroke. Celecoxib, because it only inhibits COX-2, will not have the GI side effects and platelet issues that all the other NSAIDs will have. But that also puts them at a higher risk of cardiovascular complications because it doesn't help the platelets not be as sticky. NSAIDs are metabolized by the liver and excreted through the kidneys, and are very well known to cause kidney injury at higher doses or with prolonged exposure, and I call NSAIDs kidney killers. Providers will choose which NSAID to use based on the cause of the pain, the medical history, and the intended effect and the cost. Aspirin, ibuprofen, and naproxen are all over the counter, and they're all relatively cheap. NSAIDs have many side effects, and depending on which one the person's taking will depend on which side effects they have. The non-selective NSAIDs will have GI distress that can be from mild heartburn to full-blown GI bleeding. Most commonly we see that with aspirin, but it could occur with any non-selective NSAID. COX-2 inhibitors like celecoxib have the least amount of GI side effects. NSAIDs can also cause kidney and liver damage and failure, along with bleeding issues, and may increase the risk of cardiovascular events like heart attack, stroke, and heart failure. There are several complications to taking NSAIDs, which include people who have history of bleeding, either GI bleeding, nosebleeds, or excessive bruising, and people taking the medication who are taking other medications that increase the risk of their bleeding, like warfarin or heparin. People who have kidney or liver damage or failure should not take these medications, as they cannot metabolize and excrete the medications. People who drink alcohol should avoid taking NSAIDs due to the liver damage and liver failure risk. Before we give NSAIDs for pain, we of course need to assess the pain, assess any liver or kidney studies that the patient may have to make sure their liver and kidneys are functioning, assess their eyes and nose, and make sure they're making urine, and of course assess for any allergies to NSAIDs. We also need to see if they're at risk for bleeding or GI distress. After we give it, we need to reevaluate their pain to see if the medication worked. Patient teaching and education we need to provide are similar to what we need to do. They need to be instructed on how and when to take the medications, how not to take more than the recommended daily dose. Additionally, patients in America should be avoided on drinking alcohol while using these medications. And again, that's a big part of our education because alcohol use is very common. They also need to know the signs and symptoms of GI distress and toxicity and what to do if they expect something is occurring. Aspirin is an NSAID, but it also has other properties as well as being an antipyretic and antiplatelet. It's technically called a salicylate, and it inhibits COX-1 to prevent prostaglandin production. Because it's a COX-1 inhibitor, it's also going to inhibit GI mucosa protection. It can be used to treat mild pain and inflammation as well as fever, and it's also used to prevent blood clots in people who are at high risk. The side effects of aspirin include tinnitus or tinnitus, which is ringing in the ears, dyspepsia, which is like upset stomach, gastritis, GI bleed, anemia, hemolysis, increased bleeding time, and anaphylaxis in people who are allergic to it. Aspirin is contraindicated in people with allergies to it, people with bleeding disorders, chronic alcohol use, kidney or liver damage, failure, or even like kidney or liver disease. When we educate our patients on taking this medication, we need to focus on them taking it with food, not crushing any enteric-coated forms of aspirin, taking it with a full glass of water, and avoiding alcohol. Drinking alcohol with aspirin will increase the risk of GI bleeding, and they also need to be taught the signs and symptoms of toxicity, which would include that tinnitus, agitation, confusion, and lethargy. Ibuprofen is a very common over-the-counter NSAID, and it's used to treat mild to moderate pain, fever, and inflammation. It's a non-selective COX inhibitor, and ibuprofen does have daily limits, just like acetaminophen. People should not exceed 3,600 milligrams per day from any source of ibuprofen. And ibuprofen is also commonly used in many cold and flu products, so people need to watch all sources of ibuprofen. I say that it's in less stuff than acetaminophen, but it's definitely still common in those over-the-counter cold medicines. The common side effects are going to include headache, GI discomfort like nausea, vomiting, dyspepsia. Adverse effects would include GI bleeding, Stevens-Johnson syndrome, which is that red man skin sloughing syndrome, and kidney and liver failure. Patient education is important with ibuprofen, as they need to be taught to consume the medication with a full glass of water, remain sitting upright for 30 minutes following medication administration. They should also avoid the use of alcohol when taking this medication, and they should be advised to not take it longer than 10 days. If the patient does notice GI bleeding or GI distress or any bleeding anywhere else, they need to be reported to their healthcare providers immediately. Ketorolac or Toradol is an NSAID that's commonly used to treat breakthrough pain that occurs during the treatment of severe acute pain while they're being treated with opioids. It can also be used to treat moderate and mild pain that's too much for acetaminophen or Tylenol or ibuprofen or Motrin, but it's not enough pain for an opioid. And I like to call Ketorolac ibuprofen on steroids because it's like a super strength ibuprofen. Ketorolac works by inhibiting prostaglandin synthesis, and it's indicated for short-term, like up to 5 days max, management of moderate and severe acute pain that requires that analgesia at the opioid level, but we don't want to give them opioids. It's used a lot in the emergency room and in urgent care and in the hospital. Ketorolac is not without its side effects, which can include drowsiness, headache, GI bleed, dyspepsia, nausea, Stevens-Johnson syndrome. It can cause edema, and it can absolutely cause renal failure. It is an NSAID, and like I said, NSAIDs are kidney killers, so we got to watch those kidneys. It also has a very well-known side effect for causing GI bleeds that can be fatal, so we have to watch for that as well. When we teach our patients about taking Ketorolac, of course, they need to know how and when to take the medication, but they also need to know they need to avoid alcohol or other aspirin-containing products unless directed by their healthcare provider. And if they notice a rash or any GI pain or any GI symptoms, these should be reported to the healthcare provider immediately. Celecoxib or Celebrex is a common NSAID that you may see people take at home. It's a COX-2 inhibitor, which means its mechanism of action is to inhibit the enzyme COX-2 that's required for the synthesis of prostaglandins. It's used to treat pain associated with osteoarthritis, but it's not without its issues. Some of the adverse or side effects include hypertension, peripheral edema, increased liver enzymes, abdominal pain, dyspepsia, gastroesophageal reflux disease, vomiting, and diarrhea. A couple years after it was released, it was found that the company who made this drug lied about the cardiovascular side effects like heart attacks, which made them have to issue a black box warning. Black box warnings are major warnings for providers to make sure they're using the drug for the appropriate person. The black box warning for celecoxib is due to the increase of cardiovascular events and GI bleeding, ulcerations, and perforations. So when we do patient teaching and education, we need to instruct them to take the medication as directed and to use the lowest effective dose for the shortest period of time to hopefully prevent any of those GI or cardiac problems from occurring. If the patient isn't being well controlled with non-opioids, or if it's moderate to severe pain, the provider may order an opioid or narcotic medication. There are several types of opioids, but I'm only going to focus on the more common type, which is the mu receptors, which are pain-blocking receptors, and they are actually called opioid agonists. They work in two ways, the first being blocking the nociceptive afferent nerves to inhibit the release of substance P to stop nociception. The second way is by helping the mu receptors to cause pain relief and euphoria at the spinal cord level of the nervous system. Mu receptors also cause respiratory depression, sedation, decreased GI motility, pupil constriction, and development of physical dependence. So knowing this, you should be able to start thinking about what kind of side effects we may have from opioids. In Block 1, we only discuss oral and parenteral medications, but there are a lot of opioids that are given intravenously to get faster pain relief. Oral opioids have to go through the portal system in the liver and has that first pass effect, so it can take 30 minutes plus for a person to get pain relief from oral opioids. IM and sub-Q opioids have faster onsets than oral, but if we're dealing with severe pain, IV route is the most commonly chosen routes. In urgent care, you'll see IM opioids given all the time, and at home it will be oral. If we're in the hospital, it may be oral and IV until we can control the pain completely with oral opioids. And most opioids are metabolized in the liver and excreted through the kidneys. There are so many medications in this drug class, so I wanted to list some of the more common ones that you might see. Now, depending on where you end up working as a nurse, you may see other types and you may even use opioids from different classes that I'm not discussing here, but these ones are common in most places. First, we have codeine, which is just a generic medication, and it's pretty good for moderate pain relief, and it can be put into cough medication because it's really good for helping cough-related pain. Then we have fentanyl or Duragesic, and this is typically used for pain relief in surgery and in PACU or the recovery room in the IV form, but it also comes in patch form, lollipop form, and usually we'll use it like that for people with moderate to severe cancer-related pain. Next, we have a hydrocodone or Hysingla, which is not very commonly given by itself. So you're typically going to see this in combination form with acetaminophen, and that drug combo can be called Lortab, Norco, or Vicodin as some of the common brand names. This is used a lot for moderate pain that's controlled on oral medications. Next, we have hydromorphone or Dilaudid, and this is given for moderate to severe pain in its IV or IM form, but it does have an oral form version. Next, we have morphine, which is very commonly used. It has oral, sub-Q, IM, IV, and even aerosol versions. It also comes in immediate release and extended release versions, so it's a really good drug for acute or chronic pain. Then we have oxycodone or Oxycontin, which can be used alone or in combination with acetaminophen to create Percocet to treat chronic or acute pain that is controlled on oral medications. Opioids work great to relieve pain, but they're not without major risks. I already mentioned the effects opioids have on mu receptors, so you know they can cause euphoria, respiratory depression, sedation, decreased GI motility, pupil constriction, and can develop physical dependence. All of these can turn into adverse effects if we give too much medication or if the body's not clearing out the medication as it should. The sedation can turn into respiratory depression, causing them to breathe less than 12 breaths a minute, which could turn into full-blown respiratory arrest, to cardiac arrest, and to death. Opioids can cause hypotension, especially orthostatic hypotension, so we need to monitor their blood pressure closely and be extra careful when they get up, as they can get dizzy and their fall risks. They can also cause nausea and vomiting, and the decreased GI motility, which will cause constipation that can cause the bowels to completely stop. They can also cause urinary retention, and opioids can also cause psych issues like psychosis, anxiety, fear, and hallucinations. As far as contraindications, there are too many to list, but obviously an allergy to the opioid is a contraindication. There are also many drug-drug interactions, usually if the person is taking more than one medication that can cause sedation and respiratory depression. They can work together a little too well and cause respiratory arrest and cardiac arrest. And there have been situations where celebrities like Heath Ledger used opioids in combination with sleeping pills and accidentally overdosed and caused respiratory arrest and cardiac arrest and died. We also want to use these medications cautiously in people who have addiction issues. Now, this is a very ethical dilemma situation because some providers will deny opioids to addicts, and they are very much in pain and need the pain medication to treat the pain. So those patients won't get the pain relief they deserve. And this is going to cause so many issues for the addicts in terms of mental health and from complications of not having their pain relieved. We also want to use opioids cautiously in people with known respiratory dysfunction where their breathing may be significantly affected by the opioids. There are a lot of nursing implications we need to be mindful of when we administer opioids. First is making sure we do a good assessment before we give the medications. This includes pain assessment as well as vital signs and assessing bowel and bladder function, which includes I's and O's. We also need to evaluate the effectiveness of the medication after we give it. When we give the medications, remember it's better to try to keep the pain medication given at a set schedule to help keep the pain controlled than to let the pain get out of control and end up having to give a lot more pain medication. Keeping pain controlled will help the risk of complications and will keep the patient more comfortable and happier with the pain relief. Be sure that you're following the orders, of course. We also want to make sure we're following a bowel program for the patient, meaning we're giving them increased fiber, stool softeners, or even laxatives to make sure they don't get constipated. I've seen so many times where nurses didn't give anything to help with the bowels, and then a week goes by with no bowel movement, and the patient is miserable, and we're giving them so many laxatives and enemas to get them to have a bowel movement, when we could have just given them a stool softener every day and prevented all of this. We also want to treat any nausea with antiemetics like ondansetron, which is Zofran, and encourage them not to take the medications on an empty stomach to help prevent the nausea. We need to make sure that any sustained or extended release opioids are not cut, crushed, or chewed. If the patient goes home with pain medications, they need to make sure that they're not driving or operating machinery when taking the opioids. This is a DUI offense in many states. They also need to know not to drink alcohol or take other CNS depressants at the same time. They should keep a diary of the pain and the medications they took to treat the pain so they can bring it to their provider's office. They also need to know the signs and symptoms of physical and or psychological dependency if they're taking the medications for a long period of time, as well as the signs and symptoms of adverse effects and withdrawal symptoms. This device right here is called a PCA pump, or patient-controlled analgesia pump, that's sometimes used to relieve pain in the hospital setting. They deliver intravenous opioids at a set rate with the ability to have the patient give themselves a little extra dose at set intervals. PCA pumps come in waves, meaning you may use them a lot for a period of time, and then they aren't used for a while, and then they're used again. I think it's pretty provider specific, but it seems like PCA pumps are popular about every 5 years or so. I have pictures of 2 common types of PCA pumps, but there are a lot more out there. PCA pumps are portable and computerized and contain a chamber for a syringe or bag that's going to deliver a small preset dose of opioid. To receive a demand dose, the patient presses a button attached to the PCA device. The pumps are locked so they can only deliver what's programmed, and only people with the key or the code can change the settings. I just want to reiterate, these are patient-controlled analgesics. Families should not press the button for the patient, and they definitely should not push the button for the patient if they're sleeping. If they're asleep, their pain is well controlled, or they may be oversedated, and that could be an emergency situation. If we have a patient who is having respiratory depression or too much sedation from opioids to the point where the patient's in danger, there is a medication we can use to reverse the opioids. It's called naloxone or Narcan. This is a very powerful narcotic antagonist, and when we use it, it's going to reverse all the opioids in the body, either fully, like 100% completely, or at least partially reversed. This situation usually occurs in people who are opioid naive, meaning they don't usually take opioids, and a little bit of opioids has a powerful effect on them. It could also be someone whose liver and kidneys don't work as well as they should, and they're not excreting the medications as quickly as needed, and the drug builds up in their system, and they have adverse effects like the respiratory depression and oversedation. Naloxone competes with the opioid receptors in the brain to prevent opioids from binding to the receptors, and will actually displace opioids that are already occupying those receptors. Because this medication is going to reverse the opioids in the body, we're going to see the opposite of all of that, the opposite of all that depression. They're going to wake up wildly. They're going to be tachypnic, tachycardic, hypertensive. They may be diaphoretic and have tremors and even nausea and vomiting. It could even send the person into a seizure and lethal cardiac rhythms that could cause death. So when we choose to use naloxone, we need to know what could happen. Now, that being said, we don't just administer naloxone for the fun of it. We're going to be weighing the risks and benefits of the opioid-caused depression versus the adverse effects of the naloxone. If we give it, they're probably close to dying because they're not breathing very well. Now, if we are going to give naloxone to someone who's dependent on opioids, not like the opioid naive, not somebody who got a little bit too much pain medication, but people who are truly depending on it, we're going to have a different situation. The abrupt reverse of opioids is going to affect them, that person who's physically dependent, by causing acute withdrawal symptoms. Like literally, we're going to make that dependent person go through withdrawal immediately. They're going to have body aches, fever, sweating, a runny nose, sneezing, weakness, shivering, trembling, nervousness, restlessness, irritability, nausea, vomiting, diarrhea, abdominal cramps, increased blood pressure, and tachycardia. This is going through withdrawal. This is not a good situation. Okay, the withdrawal of medication has significant complications, and some of these withdrawal patients end up in the ICU. That's how bad withdrawal can get. I don't want to go any more in depth with that because that really is a more of a block 2 psych discussion, but I just want you to know that if that patient's dependent on opioids and we give them Narcan, we are going to put them in withdrawal symptoms. There are many things we can do to help pain in addition to pain medications that are not considered alternative or complementary therapies, and we call these adjuvant therapies. We use these to treat the pain or the side effects from the pain medications. As far as treating side effects, we have antiemetics, stool softeners, laxatives, and antihistamines like diphenhydramine or Benadryl to help the itching, as some people get itching when they take opioids. When we want to treat the pain, providers can inject local anesthetics or numbing medications into like joint spaces like the knees and the back to help prevent pain. There are also numbing patches and creams that we can use in addition to numbing and pain relieving patches. There are also over-the-counter pain relieving patches and creams like Biofreeze and Bengay. There are some anticonvulsants or anti-seizure medications that actually help with nerve-related pain, and they can actually work better than opioids for nerve-related pain. And the two common ones we see out there are gabapentin or Neurontin and pregabalin or Lyrica. Some people with chronic pain or emotionally increased pain may benefit from antidepressants or anxiolytics to help treat the emotional aspect of the pain as well as the nerve-related aspect of pain. We can also use muscle relaxers to help muscle-related pain, which we're going to discuss more in the next slide. Or in people with really bad chronic pain like cancer pain, providers can insert an implanted pain pump to continuously deliver pain medications inside the body. If we have someone who's having muscle-related pain, like a muscle spasm, the best treatment is to relax that muscle using muscle relaxants. There are several commonly used muscle relaxers, including baclofen, Soma, Flexeril, Scalaxin, Xanaflex. All of those have generic names that are way too hard for me to say. Muscle relaxants work in the upper levels of the central nervous system to interfere with reflexes that are causing muscle spasms. Muscle relaxers are rapidly absorbed and they're metabolized in the liver and excreted in the urine. There are many side effects and adverse effects of muscle relaxers, including drowsiness, fatigue, weakness, confusion, headache, nausea, dry mouth, and hypotension. We want to use muscle relaxants in cautious with people who are using other CNS depressions like alcohol and opioids to prevent respiratory depression and oversedation. We also want to be cautious in people with known allergies to muscle relaxants, people with epilepsy, cardiac dysfunction, and other conditions that may cause muscle weakness. Our nursing interventions will include assessing for allergies and assessing for cardiac and respiratory depression, as well as oversedation. We will monitor for side effects including strength, pain relief, bowel and bladder function, and we'll monitor kidney and liver function to make sure there's no damage to either of those. Like with opioids, muscle relaxants can make people fall risks, and they're at risk when they drive or operate heavy machinery. This is the end of part 4 of pain. I hope learning about all the good ways we can treat pain now makes you glad that we're not living back in the days where we had ether for pain relief like this poor gentleman in this picture.